Welcome everyone, happy learning, and today we will be discussing diabetes insipidus. What is diabetes insipidus? Diabetes insipidus is an important clinical lesion that needs to be differentiated from diabetes mellitus, both of which can produce polyuria and even polydipsia as well. So here there is an inability of the kidney to reabsorb water due to either ADH deficiency or ADH inactivity. So in diabetes insipidus, the prime pathogenesis factor is that either there is a ADH complete or partial deficiency, or there is lack of action of ADH. ADH becomes resistant. So let's discuss a bit about ADH or vasopressin before going towards the diabetes insipidus. So here it is, this vasopressin ADH is secreted by the supraoptic and also paraventricular nucleus of hypothalamus, transported to posterior pituitary through the long axons of the neurons. This acts on this vasopressin ADH acts on the collecting duct cells and also believed to have some action on the distal tubules. ADH activates the G protein coupled V2 receptors. V2 receptor in turn helps in transportation of aquaporin to the luminal cell membrane, and aquaporin is the channel through which the water comes in and gets through the lumen of the tubule. The common causes of diabetes insipidus include head trauma, cerebral tumors, most commonly the suprasellar tumor, craniopharyngioma, inflammatory disorders of hypothalamus pituitary, surgical procedures, iatrogenic procedures on hypothalamus and pituitary could also be contributory. Genetic basis, where there is either deficiency of production or there is a receptor defect, so mutation leading to either production of the ADH, or there is some kind of a receptor level defect of ADH that can be seen. Types of diabetes insipidus: it could be central, which is again partial deficient, divided into partial diabetes insipidus with a partial deficiency of ADH, or it could be a complete deficiency of ADH. Here there is either ADH deficiency because of the lesion in hypothalamus or in pituitary or in the axis of hypothalamus to pituitary. The connecting axis of hypothalamus to pituitary get distorted. Nephrogenic diabetes insipidus, the renal tubular unresponsiveness to circulating ADH. So here there is a receptor level defect. There is a resistance of the tubules to the ADH action. So the important causes are lithium toxicity, renal disease, and sickle cell diseases. These are commonly being implicated as the cause of nephrogenic diabetes insipidus. Gestational diabetes insipidus. Here there is a placental secretion of vasopressinase, an enzyme that destroys the ADH, that is called as vasopressinase. This particular gestational diabetes insipidus develops during third trimester of pregnancy and generally remits 4 to 6 weeks postpartum. So here what you will get: polyuria with inappropriately low specific gravity and osmolality. Serum sodium and osmolality are increased as a result of excessive renal loss of water. So serum osmolality and sodium level will be increased, whereas the urine osmolality and specific gravity will be low. And this differentiates it from diabetes mellitus, where you will get increased specific gravity and osmolality due to excretion of glucose in the urine, whereas here there will be low specific gravity and osmolality in diabetes insipidus. And because of increased serum sodium level, increased osmolality, it will sensitize the osmoreceptors in the hypothalamus of the brain to cause increased thirst generation, and there will be polydipsia that will be resulting from that. Differential diagnosis is primary or psychogenic polydipsia. Here there is a low plasma and low urine osmolality. So due to some psychogenic factors, including it could be schizophrenia, or it could be just a self-isolated condition, so where the patient drinks excess of water without any ADH defect. So that generally results in low plasma and low urine osmolality. Coming to the investigation of polyuria and polydipsia. So if the patient presents and come to you with polyuria and polydipsia, you need to do a water deprivation test. Patient needs to be water deprived for a few hours, and then the pre and post urine osmolality, serum osmolality has to be measured, sodium pre and post has to be measured, and then we need to monitor the response of this water deprivation test. So if there is a no change in urine osmolality even after the water deprivation, then we need to do kind of a vasopressin injections have to be given, and the vasopressins after the injection of vasopressin, subsequently we need to check the urine osmolality. If there is an increase of the urine osmolality subsequent to vasopressin injections, that means it is a central diabetes insipidus. Because of the lack of action of vasopressin, there was a lack of vasopressin that was causing unchanged urine osmolality or low urine osmolality. Now if there is still no change, that means even if the vasopressin is being made available, it has not and because of in nephrogenic diabetes insipidus there is a receptor level defect, so still there will be no significant effect on osmolality, and osmolality will be still low. So this case it is nephrogenic diabetes insipidus. On the contrary, if the water deprivation test is positive and there is increase in urine osmolality, but still the patient is presenting with polyuria, polydipsia, this accounts that there is this accounts for the fact that there could be psychogenic polydipsia. So psychogenic polydipsia, because here the ADH level is adequate, so there will be a change in urine osmolality on increase on the water deprivation test. There will be change in the urine osmolality because the ADH level is intact. In this case, ADH level is normal, so there will be increased urine osmolality because of water deprivation test. Now the treatment, the central and gestational diabetes insipidus are treated with vasopressin injections, whereas the nephrogenic diabetes insipidus is treated with thiazide diuretics. Now how does this thiazide diuretics act? It is believed that it causes increased sodium excretion, and increased sodium excretion will lower the osmolality of the serum, and that will cause inhibition of the osmoreceptors of the brain, and the thirst will be decreased, and the symptoms will be minimized with the use of thiazide diuretics. So let's have a quick recap. Diabetes insipidus is divided into central, nephrogenic, and gestational. Polyuria, polydipsia, low urine osmolality, high plasma osmolality are seen. Water deprivation and vasopressin challenge test are used for differentiation. The treatment part includes central and gestational diabetes insipidus are treated with vasopressin injections, and nephrogenic diabetes insipidus is treated to an extent by thiazide diuretics. So thank you for your attention and being there in the video. So please share your valuable feedback to the video. That is quite important for my response and for my progress. And apart from that, please share, like, and subscribe to the channel, and stay tuned to the channel for further updates and upcoming videos. Thank you.